Today we are going to interview Dr. Daniel Dent for the SSAT Residence Corner. Dr. Dent is a distinguished teaching professor and program director of the General Surgery Residency Program at University of Texas in San Antonio. Dr. Dent completed his bachelor's degree in psychology from Duke University and obtained his medical degree at the University of South Florida. He subsequently completed his residency at the University of Tennessee in Memphis. His residency included an additional year of research in trauma and nutritional support. He then joined the faculty at University of Texas in San Antonio in 1996. He has received numerous teaching excellence awards, including the Presidential Teaching Award at the UT Health Science Center. Dr. Dent's research focuses on trauma, autotransfusion, surgical infections, and surgical education. He is the secretary of the Board of Governors at the American College of Surgeons. He is the past president of Association of Program Directors in Surgery, and he was recently elected to be a director of the American Board of Surgery. Dr. Dent is an exceptional surgical educator, and it gives me immense pleasure to talk to him today on how to be a better surgical resident. Dr. Dent, what are attributes of the best residents that you have trained?
I think that a lot of people can describe a lot of the basic attributes of great residents. They're smart, they're hardworking, they have great attitudes at 2 o'clock in the morning, they communicate well with all members of the team, including the patient, the nursing staff, the people beneath them on the team, the people above them on the team, their peers. But I think the one quality that we don't really assess very well and that's hard to measure is the ability of a resident to recognize their own weaknesses and work deliberately on them. Nobody comes to residency gifted in all areas of what it takes to be a great surgeon. And whether you need to work on how you communicate or your medical knowledge or your technical skill, there's something all of us need to work on. And the best residents are the ones who recognize within themselves their weaknesses, and they don't wait to be called into a faculty member's office or the program director's office to be told, hey, you've got an issue, you need to work on it. They look around at their peers, they look around at the role models in all aspects of what they're trying to accomplish, and they emulate them, and they recognize their weaknesses of their own volition and work deliberately at making themselves better. And the resident that can do that is going to be the resident that can stay out of the chairman's office and stay out of the program director's office and will ultimately be a great surgeon in the long run.
Dr. Dent, what is most reflective of surgical performance during the residency? Is it the scores, is it evaluations, or is it something else completely?
So at this point, we don't have a great evaluation system. And from the data I've seen and the presentations I've seen at surgical education meetings, probably the best predictor of performance, although it's far from perfect, is actually USMLE Step 1 score. And it doesn't by any means account for all performance predictability, but there aren't other variables that we've identified that account for the rest of it. So that's why program directors place a fair amount of importance on the Step 1 score. I do know some program directors that if you don't do well on Step 1, they want to see what you can do on Step 2, because a really good Step 2 score, even in the face of a modest Step 1 score, reflects that you have the horsepower to get the job done, and a program director can view that as, this is a resident that I can work with and that seems like they're able to get the job done. And one of the things that improving your step score shows is that you're able to identify one of your weaknesses and take the effort and make the right steps to to progress and fix one of your weaknesses. And so that's a highly desirable characteristic.
So many clinically excellent residents suffer from poor test scores and vice versa. Is there any quick fix to this problem?
I'm not aware of a quick fix to a medical knowledge problem. I do think there are a small percentage of residents that truly have a test-taking deficiency or issue that is such that their test score is not reflective of their medical knowledge. But I think it's a fairly small percentage. I think a lot of people try to make something of that to account for poor test scores at times. But I think for most residents, the test score largely does reflect the medical knowledge. It may not be perfectly accurate or perfectly precise, but I'm convinced that the resident that scores in the 10th percentile has less knowledge than the resident that scores at the 50th percentile over 90% of the time. So the fix is really understanding how to learn. I think a lot of us are very bright, and we made it through college and medical school and even some years of surgical residency by reading and just learning from the reading that we do. But I think it's important that we distinguish between reading and studying and learning. Reading to me is like if you take a book chapter and you read it like you'd read a novel, and you start at the beginning and you read to the end. Studying is when you do some highlighting and you identify some key points that you want to learn and you put in some extra effort to try to learn them. But learning is when you do that plus you get some multiple choice questions or something else that helps you confirm that you have learned the material, such that by the time you're done with that material, you know it. And I think a lot of people, and I'll speak to myself, through medical school, it's fair to say I studied to avoid guilt. I would spend a lot of hours in the library and be there when the library closed so that when I went home at night I could say, well, gosh darn it, I studied until the library closed. But I wasn't there acquiring knowledge and confirming that I had succeeded in acquiring that knowledge. And I think that's the approach that you really need to take. And the residents that are reading or studying, if they would spend, number one, more time, and number two, confirming that they're learning, then I think that they would have more success in acquiring medical knowledge. The challenge with this is it's kind of like working out and teaching someone the proper technique for doing squats and push-ups. It's one thing to know the technique, but it's another thing to do all the squats and push-ups that are necessary to achieve your goal. And it's a lot of hard work. Learning surgery is a lot of hard work, and learning the knowledge side of it takes a tremendous amount of work, and it's not glamorous. And it's not even fun at times until the patient comes in that has the disease you learned about, and then all of a sudden you're very positively rewarded for the effort that you put into it.
The best surgical residents seem to have a strong sense of patient ownership. Do you think that is correlated with the quality of the surgical residents?
Absolutely. I think it's not just about patient ownership. I think it's about educational accountability. And so, for example, I think if you show up to the operating room expecting that the attending surgeon is going to have a health problem 1 minute before the case starts, and that you're going to have to do the case by yourself, but you're prepared for that, then you get a lot more out of that case, regardless of how much you're allowed to do on the procedure. And this gets to the concept of developing competence and confidence with a procedure. And the question is, how many of a procedure does it take to become competent or confident? And I'll argue that's highly variable depending on how the individual approaches those procedures. I've seen residents that can really become competent and confident in two or three of a given procedure because they approach each one as though it's the last one they're ever going to get in training, and they have to become competent and confident based on an N of one. And the best residents approach it that way. So it's that, and so that's really more about educational ownership of your own education, but it also is about patient ownership, because when you approach rounds on the patients the same way, that you're the one making the decisions, you're the one deciding, is the nasogastric tube going to come out, or does the patient warrant a CT scan to look for a postoperative abscess? Even if you have to communicate with your attending and get their blessing to do some of those things, if you take the ownership, then you will absolutely get more out of each encounter. And so a lot of surgeons couch this in terms of an old school thing about the doctor-patient relationship, and all that's true. But I think the piece a lot of people don't get is that the patient ownership then leads to an element of educational ownership, such that you get more out of each and every encounter.
Dr. Dent, thank you so much for your time. It's indeed been an honor, and thank you for all that you do for us and for our education.
Thank you very much.